Hello, my name's Jason Suggett, and today I'll be presenting a laboratory study to evaluate a pressurized metered dose inhaler with valve holding chamber use scenario in a COVID-19 situation where pMDIs are in short supply. As background, patients infected with COVID-19 and admitted to hospital often require inhaled bronchodilator therapy to manage their breathlessness. Some US hospitals are considering new ways to deliver such medications with pressurized metered dose inhalers whilst they're in short supply. One approach to inhaler management is often referred to as the common canister protocol, where one pMDI is used to treat several patients. In a COVID-19 situation, it's even more important to ensure that the inhaler is segregated from the patient, thereby allowing for reuse elsewhere without risk of contamination. One potential solution for the common canister protocol involves the use of a valve holding chamber or spacer. Valve holding chambers are widely used with pMDIs to improve aerosol delivery to the lungs. They do this by removing the coarse particle fraction and also avoid the need to coordinate the onset of inhalation with inhaler actuation. So, why not use the valve holding chamber to transport the emitted aerosol to the patient from the inhaler located remotely, with the pMDI removed after actuation? A US hospital approached our laboratory with a proposal to actuate multiple times into the valve holding chamber outside of the patient's room, or remove the pMDI and then take the valve holding chamber alone to the patient for inhalation. Would this work? They said. So the aim of the study really was to look into the hospital's interest in finding out how to maximize the delivered dose of salbutamol in a single treatment. That is, what would the relationship be between the number of actuations and emitted mass? An original proposal from the hospital had been to actuate 4 times in rapid succession into the valve holding chamber and use that to deliver to the patient. In terms of methodology, we wanted to simulate the clinical setting in the laboratory. We tested Ventolin, so salbutamol MDI, and actuated initially once into a valve holding chamber, so the antistatic air chamber plus flow view, simulating use at the medication cart in a hospital hallway. The inhaler was removed, and then the pMDI adapter port of the valve holding chamber covered. 10 seconds were allowed to elapse before connecting the valve holding chamber mouthpiece to a vacuum via an electrostatic filter to collect the suspended aerosol at 28.3 litres per minute. And the delay of 10 seconds simulated the time to enter patient room and have the patient inhale the salbutamol. So a single actuation into the valve holding chamber is the labelled use. Off-label use was also simulated. So this was 2, 3 and 4 rapid actuations 1 second apart into the valve holding chamber prior to administration. And the mass of salbutamol emitted was determined by HPLC spectrophotometry. The results are represented here in 2 different ways. On the left-hand side, the delivered dose of salbutamol is represented per actuation from the MDI. And on the right-hand side, the chart looks at the delivered dose of salbutamol per treatment, so independent of the number of actuations. As you can see, when we look at the delivered dose per actuation, the maximum is achieved when 1 actuation is used, and then it declines steadily with 2, 3 and 4 actuations. In terms of the dose per treatment, you can see the maximum is achieved after 2 rapid actuations. Anything either less or above that results in a lower salbutamol delivered. Perhaps not surprisingly, it was confirmed that the standard per label practice of actuating and inhaling 1 puff at a time is the most efficient delivery method. Rapid consecutive actuations is likely to chill the metered dose inhaler metering valve, increasing friction and reducing delivery. Additionally, such practice has the potential to increase retention of drug within the chamber itself. However, for this specific and off-label delivery scenario that was being proposed by the US hospital, the maximum amount delivered as a single dose was achieved following 2 rapid actuations and as such can be considered optimal. Less than or more than 2 actuations resulted in lower total delivery of salbutamol. In conclusion, the most efficient and effective delivery method remains that recommended in the device instructions for use. So 1 actuation inhaled at a time, as well as inhalation as soon as possible after actuation. However, this laboratory-based study has indicated that a modified common canister protocol with an anti-static valve holding chamber as the aerosol transfer vehicle has the potential to be a viable off-label proposition in hospital situations where there is an urgent need to conserve pMDI medication as well as avoid cross-contamination from pathogenic viruses or bacteria.